representatives of the press and members of the public. We will proceed via video conference due to access restrictions for the COVID-19 pandemic, and papers will be published on the website in accordance with normal practice. Nods will suffice. Thank you very much. Okay, you're very welcome. As Peter helpfully said, it would be very good if you could mute yourself when you're not actually speaking, otherwise we'll get a lot of background. And secondly, please feel free to use the hands up symbol and the chat function. And hopefully I will be able to see both all of the time on a variety of gadgets around me. So you're all very welcome to our Council of Governors meeting. We do have apologies from... Sorry? No? Okay, we do have apologies. Somebody's not muted. Okay, we do have apologies from Trevor Shipman and from Debbie Needham, the hospital CEO, and from a newly elected staff governor, Dr. Vijay Kalathi, and the newly elected public governor for West Northants, Rashmi Shah. So if we can go straight on to the declarations of interest, I obviously have a declaration of interest in item 5.1, and I'm taking it as read that the non-exec directors have a declaration of interest for item 5.2. Is there anything else that we need to cover? No. Richard.
Sorry, Alan. Just a couple more apologies. Also from our new public governor for Wellingborough, Vinod Patel, and also our staff governor, Claire Jennings. Thank you. Okay, thank you, Richard.
As I said, you're all very welcome, and obviously we've had an election in the meantime, and I have a list of new governors to welcome, which I hope is complete. You can tell me if it's not, but we have welcomed two new governors: Vinod Patel for representing Wellingborough, Dr. Anup Pandey representing Kettering, Rashmi Shah representing West Northamptonshire, Simon Bayliss representing East Northamptonshire, Dr. Paul Bremner representing the rest of the UK, and staff governors Claire Nebb, Claire Jennings, Charlotte Smith, Dr. Toro Senger, and Dr. Vijay Kalathi. Have I missed anybody? Richard, you're going to tell me I have, which means your wrist was wrong.
Not as well, with the caveat that I've had some late correspondence with our new representative for Northamptonshire Council just this morning, so I'm pleased that Councillor Jenny Bone has also been able to join us this morning as a stakeholder governor for Northamptonshire Council.
Okay, you're very welcome, Jenny, Councillor Bone, and I did hear you at the start saying you just received the email in your junk folder, which is not a good start, really, is it? But I'm sure it will all sort itself out in time. And we also have to extend an extension of term. Dr. Andrew Stevens will continue as the stakeholder governor for Mind for another 3 years. And can I just say to new governors that there is a bit towards the end of the meeting under item 6 where we will invite you. Peter has suggested we invite you to do just a very short thing about why you wanted to become a governor, what your interest is, or whatever you feel the need to tell us at that point. So that's all the formalities over. You're all very welcome. Obviously, Polly is here today as our Director of Strategy because Debbie is on holiday in the Canary Islands, I believe, which gives rise to all sorts of PCR tests and all sorts of comments. She did join for the board meeting yesterday, which I thought was quite sacrificing of her, but there we go. So minutes of the previous meeting held on the 1st of September and the 28th of October, are you happy we take them as a fair record? Again, nodding will suffice. Yes, good, thank you very much. And the action log, 2 elements of the final action point remain ongoing, all the others are closed. Are you happy with that action log? Yes, that's a yes, is it, Peter? Yes, good, excellent. Thank you very much. No hands up, no. And straight into the Hospital Chief Exec report, which of course is this occasion is done by the Hospital Director of Strategy, Polly Grimmett, who is rapidly becoming our jack of all trades, but happily she's also master of quite a few. So Polly.
I'm glad you added that bit at the end, Chair. Thank you very much. And so welcome to all our new governors. So some of you won't know who I am. So as Alan says, my name is Polly Grimmett. I'm Director of Strategy at Kettering and now working across the group on a number of different things. So I've been here about 5 years now, so getting my feet slowly under the table, but nice to see you all and welcome. So yeah, delighted to be here for Debbie. And I've got a few things that I will give you an update on, and then I'm sure there might be some questions which I'd be happy to answer. So in terms of COVID, first of all, so in terms of our numbers that we have in the hospital at the moment, pleased to say that currently we are seeing a decrease in our numbers. So we've got 32 patients in with us as of close of play yesterday. 3 of those patients are in ITU. So positive that we're starting to see a bit of a decrease, but of course, as I'm sure everybody has seen in the news over the last few days, there's lots of news at the moment, isn't there, about the new variant. So in terms of, we haven't recorded any patients with that, but that's new testing that has just arrived. So in terms of where we are with that, we are just going through, there's been some national guidance that's released about our staff, for example, who might be in some of those countries affected and now have to go through additional isolation procedures before returning to work. So we're just doing some reviews at the moment as to the impact of that. And we're also reviewing our infection control guidance. At the moment, our infection control guidance remains exactly the same. We were in a position where we were thinking that we would start to review to see if we could reduce some of those guidance, but actually we've kept them exactly the same until we understand more nationally about this new variant and what that might mean. So that's where we are with the pandemic. In terms of how the hospital is doing generally, it's very, very busy with emergency pressures, as again, we're no different than any other hospital that you would have seen that in the national press. So really busy, and our staff are working very, very hard through our urgent care pathways and in all of our wards, actually, because a lot of our emergency patients are in a lot of our beds. Patient safety absolutely remains everybody's top priority, and we are focusing intently on that. The other piece of work that's going on, I think somebody's just come off mute, but the other piece of work that's going on with some strong focus at the moment is on patients who are in our hospital who are medically don't need to be here. So we do have a lot of patients at the moment who could be in other settings, and it will probably be safer and better for them to be in other settings. So we're working really hard with our system partners to facilitate those patients getting where they need to be rather than remaining in our hospital beds. In the meantime, we are continuing to do our elective work where possible and recover our elective position. So we're still doing a lot of elective procedures, not as many as we would hope or as we would want because of those emergency pressures on our inpatient beds. But we are, I'm pleased to say, we do still have some of the lowest waiting times for elective waiting times nationally, let alone regionally. We perform very well on that, and our percentage performance figures at the moment of the number of elective patients we're treated, again, are very strong when you compare us to some of our regional peers. So that's the work in the hospital. I can see a couple of hands have gone up. Shall I come to the end and then answer all the questions, Chair, or would you like me to stop at this point?
No, I think we'll gather all your comments, Polly, and
okay.
You may find you're answering them automatically, but we'll pick up all the comments at the end. Thanks.
Okay, thank you. So I was asked to give you an update on falls because I believe Debbie has spoken here about falls previously. So Fiona Barnes is leading the improvement work against falls, and we've made some really good progress. So extensive work she's been leading has been undertaken to reduce the harm for patients that do fall in our hospital. So as part of the improvement programme, there are 4 different work streams, and we are doing audits twice a month as to how we are getting along with that. And we have demonstrated, I'm pleased to say, really good sustained improvement on all of those work streams. So we've got compliance targets on those audits of 90%, and we are at 94% in each work stream. So just what does that mean in reality to the likes of us that aren't into compliance percentages? So the national average is 6.63 falls, and our average per 1,000, and our average is 3.8. So Fiona gave me a graph that I can't share, but it shows some really, really good improvements and a very strong downward trajectory from January to where we are now. So really good work on falls. In terms of other things that we've got going on, certainly still in Fiona's domain at the moment is a new complaints procedure. So again, a lot of work that's been happening over the last kind of 6 weeks, 2 months on improving our complaints and how quickly we can get back to patients and their relatives. So some very good work that's been done on that, and we've launched that. And I believe Richard Apps is going to be organising a specific workshop with the governors over the next couple of months on the details of that new complaints procedure, so you can start to become familiar with it and get engaged with it. Yesterday at our public board, for those of you that weren't able to join us, we approved a document that we call our Group Clinical Ambition document. So that's setting out the opportunities that we feel, working with Northampton Hospital, our clinical opportunities to really improve care for patients and improve the experience we give for patients. So that sets out some areas of strength where we really want to grow our services and grow the offering that our patients can get in county without having to go out of county. And in particular, that's around cardiology services and around cancer services, and we've called them centres of excellence. We've also identified there where we've got some fragile services, so those where we've got quite a small workforce that are a bit unsustainable. Patients may get cancelled appointments, for example, if there's only one surgeon and that person happens to not be here. So we're really looking to build and work with our system partners to build those partnerships for our fragile services, and also work across the ICS so that as where feasibly possible and clinically suitable, patients don't need to come to an acute hospital site for an appointment or for treatment. So hopefully they'll be able to get seen and treated by an appropriate clinician as close to patient homes as possible. So that's our clinical ambitions document. I'm really quite proud of it. But what we're really keen to do over the next 3 months, and I'm quite keen to, Peter, we talked about this, but talk to the governors about how we can work to do that, is go out to our patient groups, go out to our patients and our local public, as well as our stakeholders across the ICS, so our council partners and our community and mental health partners, talk to them about what we think our ambitions are to improve patient care, and actually listen to all of you, all of those thoughts, and really feed that back into the document over the next few months, so that by the time we come to the end of March and April time, we've got a really strong document that doesn't just reflect what our senior clinical teams think they need to do, but also listens and reflects as to what our patients think we should be doing. So Sheila, we mentioned before the meeting started, didn't we, about coming along to Health Watch and getting their views, but keen to work with the governors to use all of the links that you have in your communities to enable us to really do that in a meaningful way. So hopefully that's going to be some next steps that I can be a direct link with the governors to do that work over the next few months. Couple of other things that I'll just update you on, as it's part of my day-to-day portfolio, is our HIP2 programme, and I know that my team have been talking to the governors, and many of you have come onto site in recent weeks and had a look round to understand, because it's quite difficult, isn't it, when you see PowerPoints, to understand exactly what the plan is and what's happening where and what the impact on the rest of the buildings might be. So hopefully as many of you as possible came onto site with Richard Cook, my colleague, and got an opportunity to do that. But this is just confirmation really that we're continuing that work. We're continuing to work really closely with the National Hospital Programme team to progress with our plans and our plans at pace and as far as you know them. So that work's continuing, and hopefully we can, Richard will be leading the work to keep the governors engaged with that and representing the different views so we can make sure we've understood all of that. And apart from that, the only other thing I was going to mention, actually, I was going to bring Richard May in. Richard, did you want to give just a quick update on the new membership and engagement officer that we've been successful appointing? If he's there.
I can very briefly say that we interviewed on Monday and have made an offer, had a strong field this time, so hopefully have someone in post early in the new year to really help develop and deliver our membership and engagement strategy and build bridges with the patient experience function and with our comms team. So really exciting opportunity there. Thank you.
Thanks very much, Richard. And the final thing I was going to bring up is we will, as I'm fairly sure most of our governors who have been here for a while will know, but for new governors you may not know, we'll be moving towards a full ICS model across Northamptonshire from April. And we've got some really key roles and key parts we want to play in that, with with my own portfolio, I'm the lead for elective care across Northamptonshire, and we'll be moving towards a lead provider model for elective care. Now, I don't propose at the moment to go into the detail of what that does mean and doesn't mean, because it's very complex, even for those of us who live and work in it every day. But what I would like to ask for, Peter, with your permission, is perhaps a bit of a dedicated session with the governors on what that lead provider for elective might look like and what we might want it to look like, because we've got an opportunity to form that and steer that. So I'd really be delighted to kind of talk to you separately about what that might be, if that's okay. Perfect. And that concludes the things that I wanted to say, Chair.
Okay, thank you very much, Polly. Very comprehensive. I've got 3 hands up, but we can take some more if they rise. So Mo first, then Sheila, then Paul. Mo.
Good morning. Thank you very much, Polly, for that clear summary. You really are a master. I have 2 points really to discuss. Patients who are unable to leave because of non-medical reasons should really be looked after by a different entity. And we don't need to go outside the country to see what people do. Chester County Hospital have successfully used social services, and they have them around 24/7, even in accident emergency wards, all departments. And they actually do help the patients very well by connecting them to resources, looking the minute the patient goes in, they start working on how to discharge them. These are the social services here. But we as governors, really, we need a bit more clarification on what these people are capable of doing. So it would be nice to hear someone who works in that field. The second point is your ambition about clinical services to patients in Northamptonshire. Is the principle here the patient goes to the doctor or the doctor goes to the patient? Which way are you going to provide these services close to patients? And I'm just fearful of fragmentation of the service. Thank you.
Okay, thank you, Mo. We're going to gather these questions, so some of them might group together and make it easier. Sheila.
Thank you, Alan. Yes, mine does. I was going to talk about something that we discussed yesterday at our pre-meet, which was the information that there were 119 super stranded patients and 66 of them were looking for a pathway in the community. Because of the various committees I'm involved in, I know there's a lot of work being done in the community about prevention, things like the Public Health Falls programme and things like that. What I'd like to know is what actually is being done to provide more. This is such an old chestnut, as it were. I can remember some years ago being involved in a Think Home First idea that never came to fruition. I know social services are short of money and short of staff. Has anybody got any wonderful ideas about what can be done to actually do something for care for these patients?
Okay, thank you, Sheila. Paul.
Hi there, thank you. Just one question about the outreach, if I may, and also a quick comment at the end. What resources would you be planning to provide to governors to engage with the public? Would there be online forums, online quizzes? Would there be an MS Teams form or other form of online interaction? And would that be presented in a very simple and very clear way on your website, and it's easily accessible? I'm also, this is the final comment, I'm also a district councillor. This is not the reason I'm a governor, but it might be helpful as I'm the rest of the UK governor, that the functions through the district council and also with local media. I have good contacts with our local radio station, Harbour FM, and I live in Market Harbour, so I'm in the hinterland of Northamptonshire, and that is the reason why I'm a governor, to represent those in the hinterland. And I would just want to offer that to the professionals represented, and if I can be of assistance using those offices, it would be a great pleasure. Thank you.
Thank you, Paul. Duly noted. You made a similar offer at the new governor's induction thing.
Indeed. Yeah.
You're clearly very determined for that offer to be taken up, which it will be, I assure you.
Thank you.
Mabel and then Faisal.
Thank you. It follows very nicely on from what Paul said. At a previous meeting, Faisal, who's one of the staff governors and an orthopaedic surgeon, believed that many of the falls could be preventable. So I've suggested we write an article for the Evening Telegraph together. So we're planning to do that and get it out as soon as possible. So if it prevents one fall, that's all to the good.
Thank you very much, Mabel. And as you know, we're very keen to support you in your conversations with the local newspapers and the articles you produced before. So that will work extremely well, I'm sure. Faisal and then Andrew.
Thank you, and good morning, everyone. I just want to ask an important question, because this is about we go through the cycles of change in care. Sometimes we reinvent the same cycle. So when it comes to super stranded patients, what I would like to know is that we had recently, in last 2 years, we have great digital inroads in our hospitals. So we used Careflow Connect, and the technology is great success for communication. But what I realized was that there is an issue about when patients come through the door in A&E, and when they put a referral into Careflow Connect, it's a one-way system. These patients will be admitted without whatever it be within 1 hour. If the people who, whichever department it is referred to, if they don't take a decision within an hour, the patients will be automatically admitted into the ward. So that is so when we did discuss about this from the department point of view, there were the points what we got from them was the national criteria is something like that. But this is where I think what is happening is that more patients, maybe unwanted patients, or maybe patients who doesn't need admission, get admitted to the ward. Then their discharge becomes an issue. Then this gets super standard or standard. You can call all this jargons you can use. But what I'm saying is that, so now to address that particular technology issue, now we have formed another team known as criteria to admit. So criteria to admit is another layer of people, clinicians, managers, all of them we are trying to see how to mitigate this. But I feel instead of, how will I say, closing the major cavity, we are trying to address with small patches. So if we decide because ED has got loads of pressure, people coming and waiting, you are hearing in the news and everything, but how do we should, this is, I'm saying traditionally, or for last 20 years, this is what I've seen. If we have a written protocol or a policy between ED and the rest of the departments, multi-department, which is a huge work, I agree. But the amount of work and time we spend through our managers and through our clinicians, why can't we spend some time to really spend in making these policies between departments and ED? Then there's no confusion between clinicians. When the patient comes in, if we know if this touches this particular diagnosis, that goes admission, and this doesn't get admission, straightforward. But that written policy is not there. Not only in our hospital, most of the hospitals do not have. And this will have a backflow effect on the ED admission, ED waiting times, and people waiting in the corridor. But we know that this is one of the solutions where we can give. But how do we, as a group, sit together between the departments and make this policy? I came across a few software solutions are there to address this, but main thing is, more than the technology, it's the people. It's the people who have to engage and then use the technology. Then we can address this issue. I rest the case.
Thank you, Faisal. Andrew.
Yeah, thank you very much, Mr. Chairman. Richard Cook very kindly took us around the hospital last week on this HIP 2 business, and I must admit it was very informative and very impressive. One thing that did concern me, the various plans, the number of actually hospital beds in Kettering in some of the plans is staying the same, and even the most adventurous plans, there's only a slight increase in the number of beds. And I think when we bear in mind that they're talking about building 5,000 new homes in Cransley area alone, I think we have to accept that regardless of the problem of super-stranded patients, which I accept is a huge issue, I think Kettering Hospital, to provide a decent service to the community, emergencies and doing elective care, Kettering Hospital needs more beds. Thank you.
Okay, Polly, so I think that's everybody. We've got, if you'd like to take your hand down, Faisal, I think that would probably help me. Thank you. Okay, Paul, we've got a couple of issues. We've got stuff around social services, and we know that they are struggling to recruit, and we know that they have been particularly pressed by the requirement for mandatory vaccinations from earlier this month. Might be interested in any comments from our two councillors from the Northern Unitary Authority, if they're happy to talk about the issues in social services and super-stranded pathways for that. The other issue seems to be around the communication mechanisms for our clinical strategy. And obviously our Director of Comms, Teresa, will have thoughts on that, and she's not here, I don't think. But you can surely cover that. And the final one is a little bit around the Falls agenda that you've already talked about. Would you like to cover those?
Yeah, happy to. And there were certainly some related points in there, wasn't there? So, as you quite rightly say, Chair, social services is struggling, significantly struggling with staffing levels. I think historically they always have, but it is even more so recently, in part made worse, of course, as you say, Chair, by the mandatory vaccinations for care workers that came in. But regardless of that, there were some significant vacancies and gaps, and we're trying to do some work with them, or we have started to do some work directly with them as to different workforce models, different ways we might be able to support some of those vacancies, so that will help us to get our patients into those settings rightly. In the right place at the right time. So there's a variety of different things we're trying to do to support our partners. This isn't just moving the problem from one place to another. We're all in this together for our patients, and we need to work together to solve some of these issues. And we are certainly working closer with social services than the NHS ever has done historically, to try and share workforce in different ways, in innovative ways, to try and help the problem that, Sheila, you gave us the stats on the number of super stranded patients. So those are patients that are waiting over 7 and 14 days in our hospitals when they medically don't need to be here. So we are doing some close work with social services. There are also different roles. It's not just about social services. So it's about, actually, we're starting to work more closely with the voluntary sector, for example, and with other areas. So patients who don't need necessarily social services or a package, but they could go home with just a little bit of other care support, or people that might just drop in or switch on the heating for them and do other things. So there's a variety of things that our teams, and Faye is leading the work on that, that we can do. I think I'll pick up another couple of things, because Andrew, that ties directly to your comment actually about the number of beds we need. So you're absolutely right to reflect on the fact that we're full to bursting, as are most NHS hospitals. But as we've just talked about, a number of those patients, Sheila mentioned 199, a number of those patients don't actually need to be in our beds. So if we were to be able to find solutions to get patients into the right care setting at the right time, then perhaps we would have enough beds. Or we would certainly have a lot more beds anyway. So our ICANN work across the system, that I'm sure governors are familiar with, so we're doing, the whole system is doing a huge piece of transformational work about ICANN that addresses exactly this. So identifying those patients that might be vulnerable to needing a hospital or a care admission, and intervening early to keep them well in their communities. But when patients do end up in hospital, making sure, quite rightly, as you say, Faisal, that right at the front line, that's identified that those patients will need care support, so we can start planning for those discharges right when they enter hospital and start to improve those care pathways. So big piece of transformational work that the whole system, so that's every organisation in Northampton, has signed up to and has been working on. And it has been showing improvements in the number of admissions of over 65. So that has started to show improvements, but there's an awful lot more work that we are all still doing and still committed to do over the next couple of years. So hopefully that, Andrew, that slightly addresses your point. In the modelling that we've done for our hospital rebuild, we have forecasted and looked at the population increases over the next 10, 20 and 30 years. The patients of that population increase, how many of them will be in the older age bracket and might be more vulnerable and need more hospital support. So we've done a lot of that modelling. Now, we could, that we had an option, we had a decision to make that if we do nothing, the ICANN work that I've just talked about, the work with social services, if we don't do any of that and we just continue as we are, you're quite right, we would need hundreds of new beds in the next 5 or 10 years. But actually our commitment, that wouldn't solve things for patients. That would keep patients in a hospital when they don't need to be so. So actually our commitment needs to be in working with our system partners to make sure that those patients get cared for in the right way. So that's kind of my response on that. I think that really good questions raised by Paul in terms of what are the resources that we're going to provide to governors. I will take that forward, Paul. So as Chair says, our Head of Communications, Teresa, is just putting the plans together at the moment for what our public engagement will look like and how we're going to properly engage and properly listen, and with a range of opportunities for how patients could get involved and our local public could get involved in that. So I will pick up the phone to her after this and give her some of your feedback and comments, and hopefully we'll be able to perhaps get in contact with you and work up something that works for governors and is easy to use for governors to go out to your local population. So thank you for that. And I think, Mo, you also raised a question on that, which is, how do we strike the balance between patients needing to come to hospital or the doctors or other health professionals going out in communities? And really the fundamental thing here is what is clinically safe and appropriate. So that's what our doctors have been working on. So there are lots of services, and some that we still provide on this hospital site that don't need to be on a hospital site. A lot of our outpatient services, for example, some of our ophthalmology treatments or some of our pain services. So some of those services, patients are coming onto an acute hospital site and they don't need to do so. And I'm sure you're all aware, we already provide services in a few off-site locations, some in Corby, for example, down at Nen Park and in Wellingborough. So this is about actually testing ourselves again. But there will be some circumstances, and I think this comes to your point, Mo, where we just do not have enough clinical staff to send out to all of these places. That comes back to some of our conversations about fragile services and what we need to do to make sure we are still meeting patient needs and avoiding coming onto a hospital site if appropriate, but being able to safely and robustly still provide continuity of services in community settings. So if you haven't had a chance to read our clinical ambition document, then suggest you do so, or at least the executive summary. It's quite a long document, but if you can read the executive summary, that would be great. And you'll start to see referenced in there some of the opportunities that our doctors are thinking about that could go into community settings. And that's the kind of stuff that we really want to hear from our public and our patients on. Are those the kind of things that you want to see local to your patient homes, or actually do you want to challenge us further? Have we not thought of everything and there's more stuff that you think we should be providing differently? And that's exactly why we want to listen and hear from you. And probably the final one, Faisal, is about the admission. So again, it's interesting what you say, because in our emergency pillar discussions across the group that have formed part of our clinical ambitions document, they talk about something exactly the same as what you're saying. So we talk about the fact of trying to get patients to avoid having an A&E wait, for example. It's in nobody's interests at all, from patients to the hospital to the staff to anyone, to be sitting in an A&E department for hours and hours. So we need to get much better at working with GPs, for example, and our other departments inside the hospital to say, what are the clinical criteria? If a patient is presenting with that, skip out A&E. go directly to the wards, go directly to this. And that's exactly what they've set out that they want to work on across the group to agree some of those things over the next year. So we can, I mean, we won't go into the detail of it, Faisal, because I can pick that up perhaps separately, or getting involved in some of those discussions, because we'll be launching that with a wider group of staff as well over the next few months. So I'd encourage you to get involved with some of that. But yeah, hopefully that kind of covers most of it. Alan?
Thank you, Polly. Am I all right here? Yes, thank you, Polly. Okay, I've got 3 hands up, and I'm conscious of time, so I'll try and bring it to an end after that if you're happy. So Anup, Sheila again, and Faisal again, please. Anup.
Hi, thank you, Polly, for providing the details. I've got the 2 questions. One is, what is HIP2? And second is, do you have data how many staff, KGH staff died during the COVID while serving in the hospital?
I'm sorry, what was the last question?
How many KGH staff, doctor and nurses, died while serving in the hospital?
The answer to the last question is none. And the answer to the first question is the Hospital Improvement Programme. HIP2 is the Hospital Improvement Programme. You will have heard the Prime Minister announcing 40 new hospitals. You can debate the nuances of that, but 6 of them were in wave 1. We, Kettering, are in wave 2, hence the acronym HIP2. And Polly will talk about that a lot, which is the repayment programme for the organisation. But the answer to your second question is Sheila.
Yeah, it's sort of a question and a comment. I know a lot of people in the voluntary sector, and on the I'm on the ICANN advisory people group, and my colleagues in the voluntary sector say they're having a lot more thrown at them, have been for the last few years, with no extra funding. I don't know whether you have any sway in that way, how the pot's going to be shared up when we come in integrated care. But if you expect them to do more, then you expect, them to be able to have the money to do it with.
Thank you. I'll pick up that stuff at the end. Faisal, I think your hand is still up. Oh, sorry, it is you now. Faisal.
I just want to correct one thing. I mean, it's not about admitting the patients to the ward, but before taking that decision, I really want the policy to be there, a strict policy. What I'm saying is that historically, between musculoskeletal and ED, we have never come in consensus. So this should change. We can, as clinicians, not doctors, as clinicians, managers, we have to, it's time to come, this is all, whatever we are doing it for the patient. So there is no way we can say, oh, this is, we have tried in the past many times between ED and musculoskeletal, it hasn't worked. I do not know between surgery, how is the case, like in all the cases of abdominal pain should be admitted without being diagnosed. So then it could be chest pain, we'll have the same issue. Back pain, you will have the same issue. So these things, I mean, before getting into any sort of, a complete rollout, I would like the policy need to be done in consensus, and only then we should roll out. Number one. One thing I would like to ask you is that, Polly, I saw something in other hospitals. I think it is in Sussex or Surrey. They have some sort of it is again a technology-based software which they use on day one. When the patient comes, they have in the dashboard which all care homes, what are the beds available in the community, and they start the ball rolling on day one, whichever patients get admitted, and their rate of discharge is fantastic. Really, they brought down the length of stay quite significantly. I wish we could visit the place, or to know from their experience how they achieved it. It'll be great, really. Thank you.
Okay, we're finished with this. Polly, do you want to come back on any of that before I wrap it up? No. Okay, thank you very much. Couple of thoughts, really. One, we're very keen to make it clear that our clinical thoughts, clinical ambition is written by our clinical staff. It's not been written by anybody else. It's been led by the medical directors. had support from Polly and others, but certainly it's been led by the clinical staff, and it's gone through a number of our joint clinical senates, large numbers of clinicians meeting to debate the topics. And of course, we had a large clinical conference back in October. So this is very much a clinical document, and it has to be read like that. It's a document about the aspirations of our clinicians for what they think is the best thing for their patients. We're very keen as a board to make the point that that's fine. Now we need to understand what our elected representatives, our councillors, our local authorities, our partners, NHFT, primary care, the integrated care system, and our patients through patient groups, and in the case of Kettering, of course, our governors as representatives of the public and staff think about that. And at the end of April or March into April, we will look to meld those two groups of thoughts together to give us what will then become our agreed clinical strategy. So I want to make it clear, we're not telling you what the answer is. We're now putting forward what our clinicians think the answer is, and we're open to wider thoughts. And I was very keen at the board to use the word humble or humility around listening to all the other groups about what matters in this regard. So that's the first thing. Just to flag up, one of the issues around, of course, our discharge arrangements and everything else is information. And the Northamptonshire Care Record goes live this week, where our clinicians should be able to see what's happened in primary care to any resident of Northamptonshire or anybody registered with a GP in Northamptonshire, I think more accurately. And our GPs should be able to see what's happened to patients in hospital. Our community staff should be able to do that. And that's a major thing to do, actually. And it now has uploaded all the data from practices which use a particular GP system called EMAS, which is by far and away the most common one. So that will also make a big difference. But we're very, very conscious of the pressure on social care and how we might be able to help with maybe improving care pathways or improving career opportunities for staff in social care. So, Sheila, your hand is still up. I'm assuming that's a legacy hand. Is that right?
Yes, it is. Sorry about that.
Thank you very much. Thank you. Okay, I'm going to move on to now to the integrated governance report, and we should be able to go through the 6 committees now, starting with quality and safety. Chris.
Thank you very much, Alan. We had a meeting on the 23rd of November, and we discussed a number of things that I'm going to report to you now. The first was we talked about the factors that could affect quality and safety of quality of care and the safety of patients, including the bed occupancy rate, staff availability, and giving a measure of the pressure that the organisation was under. We then went on to talk and discuss and have reported that there had been 2 COVID outbreaks on wards at Kettering General Hospital. These had been investigated, followed up, and all the necessary treatments given to the affected patients. We then went on to discuss the event that was held on the 19th of November concerning 5 never events. For those of you who've not heard the phrase before, never events are events that should never happen in a hospital, and there's a list and definitions of them. We'd had 5 over a period of 12 months. Why I'm mentioning this event is that it really was an excellent educational opportunity and showed the transparency, the honesty, and the willingness to learn of the staff of the hospital. And I applaud them all for that. It really was a superb event, which I will be advertising to other institutions that I have connections with. We noted that Dr. Manjula Navaratnan was retiring. She had been the Director of Infection Prevention and Control and had been the lead for the mortality review system within the hospital. A lot of thanks are owed to Manjula. Her work in the background, as it were, has been exemplary. A new Director of Infection Prevention and Control has been appointed. That's the interim chief nurse. And finally, we received a report and assurance about the security around the mortuary at Kettering General Hospital following the awful case from Kent. As inevitably, we also discussed the issue of complaints and noted that changes are happening to the complaints procedure, and that in the January meeting, we will receive a report which compares and contrasts complaint system at Kettering with that at Northampton General Hospital, where the complaint system appears to give better results, and we want to learn and understand how and why that is. So that's the end of my report, Chair.
Thank you, Chris. Gail, anything you want to add as the nominated governor?
Unfortunately, Alan, I was not in attendance at the meeting, so I can't comment on that. But what I would like to say is, having logged into the Never event, I would support Chris's comments, and that was an excellent event.
Lovely. Thank you very much. Any quick questions or comments from anybody else on that? No. Okay, moving on. PF&R, Damien, please.
Hi, good morning, everyone. Right, so a fair bit to go through from a PF&R perspective, and actually Polly and Chris have already trailed from an operational point of view the main headline, which is that the trust is running pretty hot in respect of capacity utilisation. A lot of the conversation in PFR from an operational standpoint was spent around the number of super stranded patients, which has been increasing. Super stranded patients that the hospital is struggling to discharge. At the time of the meeting, which was on the 19th of November, there was 119 super stranded patients. Approximately 50 to 60% of those patients are awaiting discharge into treatment pathways external to the hospital. So this would be typically social care. However, due to capacity issues in social care beds, they're not able to be discharged. I guess also interestingly, a high proportion of the remaining patients are not being discharged due to discharge issues within the trust itself, and we spent quite a lot of time talking about that because that's largely within the trust control. So this is procedural, and there is work going on at the moment to improve those procedures and to make the discharge process more efficient, such that those patients can be discharged. Also worthy of note from an operational point of view, two of the key standards, national standards that we track, which is the 62-day standard for cancer treatment referral from the GP. Performance was 81% in the month compared to an 85% target, and referral performance was 76% compared to a 90% target. The thing I would say about that is that although it's not ideal that we didn't meet those targets, we also get to see how the trust is performing against all other trusts in England. And I'm pleased to say that Kettering remains in the upper quartile of that performance, and the team have actions in place to try and continuously improve and get back towards the actual target numbers that we hope to be achieving. From a financial point of view, three key things. One, month 7th was on plan. The trust, we also received a report from John Evans, the group chief finance officer, who talked to us about the full year position. The anticipation, or the expectation rather, is that the trust will break even and yeah, he has a fairly detailed explanation as to why that will be the case. For those of you that are not aware, the trust posted a 5.8 million deficit in H1, so we actually have to achieve a 5.8 net increase in H2 in order to balance the books. The other item, the third item, is really concerns over capital spend. Not that the trust is overspending, but that we have a capital budget of approximately 13.8 million. At the time of the meeting, spend was just below 4 million, which is pretty low considering where we are in the fiscal year. So we took assurance that the executive team have plans in place to make sure that the capital budget is spent. Underspending a capital budget is not a good thing because the money gets returned. You don't get to carry that money over into the next fiscal year. There's a lot of focus on that from the executive team, and we'll continue to monitor it in PF&R. Sorry, one other thing from a financial point of view, John Evans also highlighted that cash flow is a bit of an issue within the trust right now. Again, he's putting actions in place, which basically means we'll pay invoices when they're due, as opposed to paying them early, which has been what the trust has been doing historically. And it's hoped that that cash flow issue will be alleviated by sort of January, February time. But again, we'll keep an eye on that from a PF&R point of view. Just two other things to make you aware of. We received a report, which is the Emergency Preparedness, Resilience and Response Self-Assurance Report. Quite a mouthful. EPRR is the shorthand for that. Essentially, this report says how, is the trust equipped to deal with a major incident? So that major incident could be anything like the incident in the news of the Liverpool Women's Hospital recently, through to a cyber attack, meaning the IT systems can't be used. And we took assurance that the trust does have a major incident plan that is capable of execution if one of those events should occur. It could be improved, and so we're going to receive a revised version of that paper before March 22. But the key point is that the trust does have a major incident plan that is fit for purpose. We also received an estates facilities regulatory compliance report, which essentially assures us that the trust estate is being managed in line with NHS procedures and policies. The key aspect that got picked up in the committee meeting was around the number of risks. We all know that the Kettering site is quite aged in certain areas, and we felt in the committee that there was maybe a disproportionately small number of risks captured relative to the age of the estate. So we've asked the estates director to go back and have another think about the risks and have we really captured everything. Again, it's something that we continuously monitor. We see this regulatory compliance report periodically within PF&R. So I think those are the key points. I'll pause there for any questions or comments.
Okay, thank you very much. Peter.
Thank you, Alan. Unfortunately, I wasn't able to attend that meeting, but reading the papers in advance of it, there's an awful lot of stuff going through that meeting. And I just have to applaud Damien for getting through it. It's an incredible agenda for the PF&R, and I think if new governors wanted to learn a bit more about the hospital, that is one of the committees to observe and listen to what's going on. But unfortunately, I wasn't there, but I'm sure the job was done absolutely fine. Thank you.
Okay, thank you, Peter. I got two hands up. Graham first and then David. Graham?
I'm Peter's substitute, so I was there.
Right. Sorry.
Apart from half an hour when I had to dip out for another meeting. I think Damien's covered just about everything. It was a very comprehensive meeting, and there was some very deep questioning on things like RTT and the super stranded. And one thing I don't think you mentioned, which was the UEC deep dive that they did, the urgent care one, which again, and a lot of focus, as he said, on the capital update. But those are the main ones I picked up. But as he said, there was a lot of other stuff done. It was done very efficiently and very thoroughly. So it was an excellent meeting.
Thank you very much, Graham. Well, it was good to hear. David. David?
Might be on mute.
Still is, yeah. David? Still on mute? No. No.
Sorry, I am back. Sorry, my cursor was playing up. Yeah, I just have a quick question with regards to the major incident plan and as to whether that has been tested or there are any plans to test its effects.
Yeah, we specifically asked that question, David. It gets regularly tested. Obviously, they don't run a real life major incident. I think it's some kind of way of checking that the plan works. But yes, is the short answer to that question. Could I briefly, if that's okay, David, I'll briefly come back to Graham's point about urgent emergency care. I mean, one thing I wanted to mention, actually, which probably should have mentioned at board, I went to visit the emergency department last Friday morning. I got a very comprehensive tour from Adrian, the consultant director for that. And it's absolutely phenomenal what they're doing there and the improvements that they're continuously making. And I think in the committee meeting, and it certainly came up in quality and safety, which I attended in place of Lise Llewellyn, that actually when you look at the throughput of people going through that department, the performance statistics are actually pretty good. Could they be better? Absolutely they could. And you know, things like black breaches and whatever are not ideal, but relative to the volume of people going through there, you know, it's hugely impressive the work they're doing, and I think they're on a path of continuous improvement. So I expect that to get better as time goes on. But if any of you have the time or inclination, it is well worth a visit.
Richard.
Thank you, Chair. Just wanted to support Damien's answer to David. So I can tell you that earlier this year, we did a tabletop business continuity exercise around IT and digital systems, and that was a piece of work we did across the group between here and Northampton General's IT systems. There was a certain irony in it, in that for social distancing reasons, we did it on Microsoft Teams, and the scenario we gave the IT teams was, Teams has stopped working, what do you do? So they used Teams to resolve the fact that Teams wasn't working. However, we got deeper and deeper into actually the intranet's broken, shared folder access is down. You know, how do you prioritize people who need to give clinical care in the way that they need to give it? A couple of weeks ago, there was a CBRN, which I think stands for chemical, biological, nuclear, radioactive exercise just outside the emergency department. So a few people walking around in hazmat suits, scaring the public, whilst the public were being reassured that this is just a training exercise. And on Monday next week, there will be a full hospital evacuation tabletop exercise. Not a full hospital evacuation, with people all over the organisation. And I'm sure, Damien, that will come through to your next report to PF&R.
Okay, thank you very much, everybody. Audit for Alice instead of Trevor, who's away at his daughter's master's graduation in Edinburgh. Who knew, eh? Anyway, Alice, audit.
Sorry, Alan, let me just pull that up. Apologies, I didn't know I was subbing for Trevor, so let me just pull up what Trevor's input and check that remind myself. I don't think there's a lot to report on audit. We noted the internal audit plan, and we looked at the revised IGR metrics, which I know have come to the number of the committees now, and we are due to implement from January. I don't think there is much else to talk about. There's the issue of unappointed referrals, but I think has that been discussed at this meeting previously?
Yeah.
Yeah. So I don't think it's not a busy time of year for the audit team, other than to sort of check how the internal audit progress is going. So there was nothing to note. Apologies that I wasn't prepped to talk.
Why don't you keep the Alice show going and go straight into Group Digital Hospital Committee, and then we'll come back to the People Committee.
Yeah, absolutely. That was what I was expected to talk about, so I'll be able to talk a little bit more about this. Digital Committee, a lot going on at the moment. We are thick in the stage of doing lots of digital improvements and working our way through our digital strategy. So lots going on at the moment. The things to pull out from the report would be the health intelligence work is a really key priority at the moment. We're currently in the middle of what we're calling a fire break, if you like, a a pause where we're saying to the operational teams, please stop coming in with the requests and let us get a key set of information dashboards out to the organisation. So the team at the moment are working their way through those. A number of them have been done, and we're aiming to be finished shortly after Christmas, I believe. So that's the main focus for that team, but that really will make a meaningful difference to the operational teams on a day-to-day basis. So really important stuff. The other things we've done recently, we've had our 6-monthly update on our digital strategy, working out where we are on that, what's working and what's not. On the whole, I think we're progressing to plan. We've got some issues with the EPR, starting the EPR work at Northampton, which are more around the need to seek a tender, go through a full tender process and seek other bids for the work, which is unfortunately a sort of compliance hoop we've got to leap through. But other than that, we are broadly on track. We also received a really interesting update actually on, there was a new national standard called What Good Looks Like for digital within hospitals, and we've done a self-assessment on that. We're not sure when we'll get an external assessment, probably next year we think, but we at least now know where we are internally. I don't think there's any great surprises coming out of that. I think where we scored less well was that we don't yet have a fully functioning electronic patient record, as we all know. And therefore we are to some extent a partially paper and partially digital organisation still, which gives us some risks which we're having to manage in the interim. And that I think is where we scored less well on that, as we might all sadly expect at the moment. The only other things then to pull out would be that we are involved in some of the key projects you'll hear about and you've heard about this morning, things such as the ICANN project, and we had an update on the digital team's input in supporting the ICANN project for integrated care, and also in the same way on the outpatients transformation project, which is kicking off at the moment. And we've happily had some funding for a digital solution to help with that outpatients transformation. So we received an update on that. There are some other bits in the report, but I think they're self-explanatory unless anyone's got any questions on them.
Okay, thank you, Alice. For those of you who were logged into the board meeting yesterday, we've heard a full report from Andy Callow, the Group Chief Digital Officer. Anyway, I'll go back to Mabel for Governor comment on audit, and then I'll go to Graham for Governor comment on digital. Mabel.
Thank you very much. I think Alice has been very accurate. It was quite a quiet meeting, but I think there were some points that may be of interest to governors. I did ask for a presentation on audit because there was a lot of discussion about the group joining for governance issues, but audit remains as a separate issue and has to remain as a committee. So I've asked for a presentation on audit for new governors, and I'd also asked one for anti-crime and fraud. We've had 2 meetings on that already, and I'm sure some more will be held in the new year. A couple of other things that I thought may be interesting to governors that was picked up was the fact that there's being more aggression to staff being noted, and I think that's pretty common in the NHS, but I think that's of interest. Other than that, I think that things were fairly quiet, as Alice has already said, at audit. Thank you.
Thank you, Mabel. There has indeed been a rise in aggression, both verbal and physical, and certainly across the system we've had to increase our security staff, and there's been some bigger incidents in Northampton, I have to say, than in Kettering, but nevertheless we've gone from clapping and cheering to shouting at and throwing things, which is not great, and it's the same is certainly true in primary care. So, Graham, anything on digital?
Thank you, Alan. Yeah, another action-packed meeting. This was lots on the agenda. I mean, they have a roadmap for all this digital work, and they're working through it. And it's a good guideline. We talked about the group digital strategy, collaboration. It's really good to see the exchange of ideas and situations between Northampton and Kettering, and both able to learn from each other and move with each other. Yes, the fire breaks was something that was talked about, the funding, And there was an item on robotics, which is an interesting thing for the future. So yes, another very full meeting, really good discussions, and really interesting to listen to.
A lot of governors won't know that Northampton is a national site for robotic process engineering, which started when we were very, very concerned about oxygen flow regulation during the peak of the COVID demand. Northampton, like Kettering's an old hospital, and if your oxygen flow starts to go too fast, then you freeze the manifolds and it stops. And if it goes too slow, then the patient doesn't get enough oxygen and dies. So it was a really, really big problem. And we introduced a whole robotic process engineering system, which has now become a national exemplar down there. And again, the benefits of being a group and living across the, thinking about it across the group have been pretty obvious there. Mabel, your hand is still up, is that?
That's a new question, please, following on with digital. Is there any movement as regards patient and staff ordering of food in line with recommendations, rather than bits of paper being written on? I see that Richard has organised for communication with the trust members, Civica, and looking at their information, they have ordering systems. So I think that this is something that should be looked at, because we're well behind the curve as regards patient ordering of food.
Honestly, Mabel,
Let me come back to you on that, Mabel. I have a feeling I've seen it on a plan somewhere recently in one of the documents I've looked at, but I'd need to remind myself when and come back to you. Can I email you on that one?
Yes, please do.
Yeah, it was mentioned in the board meeting yesterday as part of the 6-month strategy update, Alice.
I just need to double check when it's scheduled in.
Yeah, indeed. The actual dates I can't remember either, but it was right at the top of the list.
But it is on the radar, Mabel. You're absolutely right. But I will double check when it's scheduled for, to give you a bit of an update.
Okay, people, have I done there? Yes, I am. People, Janet.
Thank you. So the Joint People Committee happened on the 22nd of November. A number of things came up, and obviously everybody from the report so far are aware of the context that our staff are functioning in, really difficult and challenging circumstances. The people performance statistics that you see in your report are not great, but there are some things to be mindful of. And I know as I joined the call, David was having a conversation with colleagues about overseas nurses. So this did come up at our meeting, but I can tell you that whilst we have had lots of new starters, for an overseas nurse, it takes about 6 months minimum for them to actually get their license with the Nursing and Midwifery Council. The people team were asked what that means, and clearly people are employed. So these overseas nurses are employed as healthcare assistants until their license comes through. But the length of time it takes is actually set up by the Nursing and Midwifery Council. So it isn't something you can just shortcut or shortchange. It is a process that they go through. The staff survey update on the day of the meeting wasn't great. I think it was at 35%. I'm pleased to say there's been some improvement up to 43%, but that's nowhere near it was in previous years. So understandably, we do know that we've had people pulse surveys done internally, and it's really important we get a feel for what's happening there. Other areas such as the statutory and mandatory training, there's been a lot of work done to try to make that easier for people to be able to do. And again, lots of work to review that. Clearly, what we've learned through the pandemic in terms of virtual learning, etc., is being put to good use. What the committee felt and what we looked for in terms of assurance was some indication about safeguarding training, because that didn't appear on any of the reports at that point in time, and clearly is a really important area for us to consider. We were expecting a joint safe staffing report from from both nursing teams across Kettering and Northampton. They came individually, but did show a template that they intend to use. We've had a timeline set to receive that joint report in January. And the reason why that's important is actually understanding the workforce across Northamptonshire, in particular around acute care, is really significant. It also helps with an oversight and overview of planning for some of the education and training that's required. We received a report on midwifery staffing from Kettering, and clearly there was a significant discussion around the clarity of that, and also understanding when staffing levels don't hit the requirement that they needed, what actions are put in place. And the head of midwifery was able to give some assurance around that. We were concerned from the Chief People Officer. You can see in the Integrated Governance report that there has clearly been a tremendous update for the flu boosters and the COVID boosters. But like social care, we faced a similar situation by April. And there's no doubt that it's an extremely complex situation that the Trust will need to work through at the moment. So we will be receiving a further report in January to understand what will be happening with regard to that. I'm pleased to say that in my experience with the Trust, there are a number of communication and listening events that are currently taking place in the organisation. I think it's the most that I've had experience of in my time. And why I think it's a big improvement on where we've been in the past is that these events are actually followed up every week with feedback on what has been talked about the week before. So we heard about that in the committee meeting, and I and some of the governors do attend those. I think it's really important that people get feedback quickly about particular issues that are concerning them. And indeed, that's one of the recommendations from the report that you'll see in the Integrated Governance report. Not everything gets an immediate response, and further work's been undertaken. So, for example, there was some concerns around safety with regard to car parking. And some of you were on that call. I can report that at the board yesterday, the Chief Executive was able to confirm that actions have been put in place to reduce the situation and be really positive in what's being put in place to safeguard our staff. Other areas that we were made aware of yesterday at the board, which had been a particular issue, was around some training that's going to be organised and being put on for women's safety, particularly following the issues that have happened in Northampton per se. The health and well-being of the workforce is really a critical thing, and again, a big subject in our committee and discussions. And we have been following this up both with a development session and with regular reports. The team who actually facilitate and work on this, and again, governors have been involved in some of this, both as staff and other types of governors. The health and wellbeing resources that the Trust offers were put up for a potential Health Service Journal Award. Whilst not winning it, the team were actually able to showcase what was on offer at the Trust, and it was seen to be extremely positive. They're looking all of the time at how to improve on that. And the other thing that I can report is that last week the staff awards for both organisations were held. A really tremendous opportunity to hear about what the workforce were up to, what was happening, and some really great examples of how our workforce have risen to immense challenges and been real stars in what they've been able to achieve. We follow those things through at the People Committee, being able to hear on our development sessions exactly what staff are looking to try to achieve in some of the areas that they're in. But I'd certainly recommend that if you haven't been able to pick up and listen to that particular recording, it's well worth doing. So I'm happy, Chair, to stop there.
Okay, thank you very much, Alice. Janet and Sheila. You're the non-exec, the governor rep on that. Anything to add?
Yes, thank you. Well, just to say that the meetings are very full always and very interesting. And yes, I do attend as many of the listening events as I can because it's helpful to see how the staff are thinking about things. Janet and I always speak either by email or on the phone after the meetings, and found, you know, that the things that were mentioned we agreed with. The reports are getting more joined up. It was said at one point where I think Janet made the remark that we need to align the risk registers across the hospital, and work on the possibility of having a joint nurse bank to mitigate the use of agency staff in part.
Okay, thank you very much. I'll go to Toril next, and any other comments, and then let Janet finish up. She obviously wants to respond to that. So Toril, and then David, please.
My question is for Janet. What is this? I'm not aware because I think earlier Alice also mentioned about increasing the security around mortuary after the case in Kent, and you just mentioned that increased security in the parking after the case in Northamptonshire. So is there something I need to be aware?
So if I can just respond to that, the mortuary situation was a different one related to particular issues. The point about the car parking was that members of staff had said that they're not keen to walk to the car park in the dark. But in Northamptonshire, there have been a number of issues around women's safety per se, hence the reason why the chief executive is arranging for one of these safety talks to be available for all women across the piece and other staff, obviously.
Just to clarify, Janet, these are the off-site car parks we're talking about.
Thank you.
Okay, thank you.
Okay,
David.
thank you.
Yeah, Janet, I've got two quick questions, really. One is with regard to training, and the other one is with regards to the overseas recruitment. At the session that was held recently on the Never events, there were a couple of comments made which I thought were of particular interest. And they revolved around the incident on one of the wards where a patient connected themselves to the air supply rather than the oxygen supply. And the comment that was made vis-a-vis the training was that when the, staff were actually spoken about certain things, that it was discovered that they had actually been signing off on checks, but didn't actually know how to carry the checks out. Then the comment was made that it was felt that the move for some of these things, the move to online training was a contributory factor. Though people had gone through that training, it may not have been effective. So I suppose the question is there any process in place to ensure the effectiveness of the training that actually takes place, particularly where it's online, computer-based? And are people actually checked to whether they can actually practically carry out those things on the job? The other thing that came up on that same discussion was line of sight, because the patient had been moved into a individual room, and that line of sight issue became particularly important because of the staffing levels, which is a problem we know exists. And I have raised this line of sight issue in relation to the new build, because if you've got staffing issues there, then you're potentially going to have the same problem. And certainly what I've read elsewhere is that line of sight issues have other impacts on team working, communications, etc., etc. But the second point is recruitment and overseas recruitment. And there has been some feedback that some of the recruits coming in from overseas, their language skills are not quite where they need to be. Now, that raises a question in terms of how solid is the recruitment process. And it also raises the question, is that something that's being noted, and is it something that is actually being addressed internally? Because obviously, if their language skills are not up to scratch, they are putting themselves and potentially others at risk. And it also raises the question whether they're actually going to get through to their accreditation point in the preferred timescales or the expected timescales. So that's my points.
Okay, some really good questions, David. And what I suggest I do with the very first one that you said around evaluation, particularly around the point that you raised, I will take that back and ask for some feedback. It may well be one that I talk to Chris about. We decide jointly the best way forward to question on that one. The line of sight is a well-known factor in terms of managing staffing. And I'm thinking back to the years and years ago when I was a ward sister. That was a common thing in terms of making sure you have your patients being observed appropriately. And it is something that I would have expected to be a normal piece of work. Again, however, I'll check that out with the interim director of nursing, so you have it from the horse's mouth rather than mine. And then picking up the recruitment and the language skills of overseas recruits. There are standards in terms of overseas recruitments, which also require people to be competent in the language. Now, clearly, being competent in the language in a country that where your first language is easily understood can sometimes be nerve-wracking when you move to a new place to work. And I know that language skills are an opportunity that's made available for our overseas recruits. You're not able to go onto the register, same as with doctors, unless you meet a particular standard with regard to your language skills. So totally accept what you're saying. And again, what I'll do is make sure that I confirm what I've said to give you the assurance that that our staff go through all of that. Is that satisfactory?
Yeah, that's fine. I'm just raising those points because they came out and they seem quite fundamental.
Yeah, very good questions, David.
My experience of online training in the past, completely different sector, but it's you get people going through and passing online training, but they're not necessarily effective on the job because of that. It does need a certain degree of check and supervision afterwards to make sure that that learning's ingrained.
Absolutely.
So I'm curious as to what you've done.
Okay, thank you very much, guys. Jane, final comment on this bit.
It's just for a little bit of reassurance, I guess, for members of staff who are walking to and from either car parks or indeed further than the car parks and to home. At our travel planning meeting yesterday, I raised the concern that there are several members of the teams that are worried about that distance of walking, and kindly Atkins, one of the people that we are working with, has sent us some documentation on getting home safely based on some incidents that arose within the London area. So I'll be taking that to the health and wellbeing meeting later on today, and we can have a discussion about that as to how we can implement some of those findings to support our staff who are walking to and from work, especially as we approach going sort of greener and car parking spaces. So that's things are working on in the background to ensure the safety of our staff.
Okay, thanks very much. I'll just finish up with the Strategic Development Committee. Two things to say. One is that that's now a joint committee with Northampton, since Northampton is now on the, hopefully going to be on the HIP 3 scheme, Hospital Improvement Plan 3, third wave. Then it makes sense to link it with the HIP 2 work, which we've already decoded for you, Hospital Improvement Plan 2 at Kettering, as we think through that in relation to the clinical strategy, which is going out. You'll note in the papers it says there's a session on the 16th of December. We've actually deferred that life is quite complicated at the moment around the funding and discussions with MPs and ministers. Polly may want to say something about that if she's here. Polly. Polly? You still there? No?
I think she's gone, Alan.
Okay, that's fine. It's just complicated stuff. Where am I? Peter, anything you want to pick up from the STC?
Not really, Chair. I think the issues are very complex, as you say, and we're in the hands of the gods in many respects, in the sense that we are waiting for approval from the centre, and until that comes, everything is in semi-hold position. So, yeah, the committee went as far as it could do, and I think that's about all I can say on it, to be honest.
Okay, thank you very much. We're optimistic still that we will get the resources for the enabling works coming in this financial year, or at least allowing us to go forward in this financial year. Right, thank you very much. That is all of the IGR. I appreciate I'm a little bit over time here. Peter, I'm going to hand over to you for item 5.1.
Thank you, Chairman. For the benefit of our new governors, this item reflects the need that we have to evaluate the chairman's objectives on an annual basis. In this trust, we do it on a 6-monthly basis. Trevor Shipton and myself, Trevor is the senior independent director, and myself have sat with Alan and reviewed his objectives, and they appear in the papers that you've seen in front of you. These were then put to the remuneration committee, which Gail chairs, and the remuneration committee accepted them and offered them up for the governors to accept today. So the question is, are there any questions on these papers, and are we happy that we accept them as a record from and a recommendation from the excuse me, bad cold here, for the remuneration committee? Gail, do you want any comments whilst I get a glass of water to clear my throat?
No, just to support what you've said, Peter, in that they were received by the group and we endorsed the outcomes. So approval was unanimous at the group and basically have come to the Council of Governors to be again endorsed and signed off.
So on the basis of that lot, can we accept them as approved and move forward? Any dissenters? I see nothing on my screen. I don't know whether Alan's still on the call, but if Alan can see any, then no. I think on that basis, oh, what's that? There's a question. Do you want to ask your question, Ab?
Hello.
Hello.
Yeah.
You have a question?
Can you hear me?
I can, yes.
Yeah, my question is that which document we are talking about? I haven't received any document, so I can't vote on this actually.
Oh, I see. That is probably a slip upon the part of the fact that this is our first meeting.
Okay.
Richard, are you still on the call?
Yes, there's there should be a covering report at item 5.1 in the agenda pack, which should have been emailed round to everyone. Not sure if you received that, Anup.
Okay, yeah. I guess I received the agenda pack, but I was not sure that we are going to have any voting on this matter. Anyway, I will have a look at. Thank you. Thanks a lot.
Thank you.
Okay, thank you. Any more questions on that before we move on to the next item? No. Right, thank you very much, everybody. Do you want to take it on, Aaron, or shall I take it further?
Keep going, Peter. You can do the whole of item 5.
Right, 5.2, as you've seen from the papers, and I do apologise if you haven't received them in good time to read them, but 5.2 is a very similar item, except for this time, Alan and myself met to review the non-executive's performance over the same period. And once again, this was put to the remuneration committee. And as you can see from the paper, it was accepted by the remuneration committee as a true and and fair record of the performance over time. And it comes to the council as a recommendation for it to accept this as a record of how the appraisal for the non-executives has been achieved. Once again, any questions on this before we pass it through? No, can't see anything. Thank you very much, everybody. So that item has now been agreed and passed through. Richard, please.
Okay, thank you very much, Peter. Thank you for that. Welcome to our new governors. I said at the beginning that we'd be inviting new governors to say a few words about themselves and why they wanted to join the governors of Kettering. Peter, do you want to run this, given that they're your governors, and just invite them in whatever order you feel fit, and then I shall wrap up at the end.
Okay.
Around priorities and issues for the trust. Over to you again, Peter.
Thank you, Alan. Just a very quick introduction to this. I think I've seen probably 3 or 4 new cohorts of governors come into the council during my time, and the thing that's common with everybody is that the time it takes them to get up to speed. It's obviously a conundrum that we can't really overcome because people are walking into a new environment. But I have to say that new governors should be taking the opportunities to witness as much of the council meetings that they can, and the board committee meetings that they can. And the one that I thought was incredibly impressive was yesterday's board meeting. Did anybody sign into that from around the governor table? Did anybody sign into that? No? I think you missed a treat if you didn't. And I don't mean that in a sycophantic way. Sometimes the board meetings can be a little bit dreary, but I have to say that yesterday's was a very long meeting. I have to say, Alan, it was a long meeting, but it was a massive meeting in terms of information. So I would commend to you that in the future, if you have got time, please sign into the board meetings. You'll learn an awful lot about how the trust works and how it performs going forward. I think also what we want to do in the coming year is, now we have a virtually a full cohort of governors, to try and develop some more working groups. These will reflect your interests, but more importantly, to shadow the interests of the trust. So we will work with you over the next 6 months or so to try and look at what we can do, set up some interest groups, involve you with your skill sets, and looking around the table. There's an amazing amount of skill in the council now, so we want to try and make the best of that. But moving on, because time is important, can we go and do a quick synopsis of people? I've got a hand up. Torres, do you want to ask a question quickly?
Hello. I just wanted to ask if we have missed the board meeting, is there any way we can access the recordings?
The board meeting was recorded yesterday, and I'm sure Richard will direct you to where you could hear it. You have to be prepared to put 4 hours to one side, though.
Yes, I put the link in the chat for this meeting. It's on our website, the YouTube recording, Toll, so I can send you the link to that separately as well.
Lovely, thank you.
All right. Let's just quickly go around the table. It's a quick synopsis of who you are, what your interests are, and in some ways, why did you want to become a governor? Now, you put in, when you applied, a little mini CV, if you like. So you don't really need to read that. It's just a bit of the emotional stuff here. So let me go to Vinod, our new Wellingberg governor.
I think Vinod's have sent his apologies today, Peter.
Oh, well, I'm sorry. All right. Well, how about Simon Bayliss? And let's go that way.
Okay.
Good morning, Simon.
I've unmuted. Good morning, all. Okay. Thank you very much for the opportunity. I have to say, I'm learning an awful lot. Quite a lot of it is about things that I don't know, so it's opening up lots of questions, but it's really interesting. As you said, Peter, I put a mini CV in my application, but without going into detail on that, my background in the last 20 years is HR, HR management, training, management development, and latterly, particularly, the development of organisational culture and the behaviours within the people in that culture that will lead an organisation to succeed in delivering that culture and delivering good customer service, if you like. So I'm partially retired, so I've got the time to do this. How I got into it is a bit convoluted, but it has to have started with me thinking as a civic duty I ought to go and have some involvement with the patient participation group in my local surgery, which Mabel is also on, and I'm very grateful for her for being there, for her being there too. And then kind of via, I don't know, a circuitous route really, I finished up on the adult patient group, pathway group for Northampton Trust, and then was encouraged to join this trust and then to stand for governorship. Again, I've got Mabel to thank for that, and I'm grateful to that. For her sins, she's now my guardian angel on this, and we will be getting together because I've got a lot of questions, and for Mabel and then possibly for Victor. What I want to get out of it is, I suppose, primarily what would interest me is the whole issue of joined up healthcare. All of the organisations involved, from the surgery and all of the charities that offer lots and lots of support, up through to the hospital trusts, getting people healthy enough to delay any treatment for the process of aging, and to delay treatment for things that they ought not to catch because they're not doing enough exercise or eating the wrong things, and so on. You all know about that. I think there's a huge amount of work to be done if we can kind of mobilise all the relevant forces, and that's what I'm trying to do. I'm also quite interested in listening to that last comment about you starting working groups for new governors. Music to my ears, because if there's anything that I can do within my speciality of people around the process of particularly of evaluation of training, of why people leave, what it is about the organisation. Most people don't leave the job, they leave their manager. So I mean, that's a generalisation for organisations. I don't know how that fits the model of the NHS, which is kind of, you can't qualify unique. Things are unique or they're not. Let's settle that it is unique. But that is all of that something interests me. So I look forward to, I'm going to try and attend lots of these meetings, at least initially, until I settle in and learn. And I'm going to be asking, one of the questions I'll be asking is about tours. I want to go in and meet people and see the problems firsthand. So I think that's, unless anyone wants to ask me any questions, I think that's all I've got to say.
Thank you, Simon. That was a very comprehensive resume. I'm conscious, as Alan keeps saying, about time, so I'm going to move on, but I'm sure colleagues around the table will contact you if there's any issues that have struck a balance with them.
They'd be welcome.
Thank you. Anna, can I ask you to come in next? Anna from Kettering.
Thank you, Peter. I'm Anukor Pandey, Dr. Anukor Pandey. I've been elected as a unity councillor. So I thought I strongly believe that I can work as a bridge between my constituents and the healthcare KGH here. I bring nearly 20 years of a corporate experience, and my expertise in deep learning, interest in digital health and use of artificial intelligence in hospitals. I believe that I will be able to contribute something and witness the KGH and other hospitals adopting more and more artificial intelligence for the benefit of the patients. Yep, that's it. Thank you, Peter.
Okay, thanks very much for that. Interesting topic there, and I'm sure we'll be able to talk with you a bit more about how that can be working across the hospital trust. Thank you. Rashmi, is Rashmi with us this morning?
No, Rashmi isn't, Peter. No, he sent his apologies.
I'm sorry. I should have taken notice at the beginning, shouldn't I? Sorry. Okay, Paul Bremner, please. Paul, I know you're here. You've asked a question.
Thank you.
Off you go.
Paul, you've muted.
The most problem. I'm an academic at De Montfort University, work in the School of Pharmacy, and that might be of interest to some people, I don't know, particularly with placements. I'm a district councillor on Harbour District Council, so my interest is the people. I'm in the hinterland, as I said, in the rest of the UK, and I chair the Audit and Standards Committee at the council, so I'm interested in audit, and I would really just like to engage with Peter as my buddy and learn a lot more about Kettering Hospital. And I would like to say thank you to the chair, Alan, because I think he chairs this meeting really well, and I will sign off now to give you more time. Thank you.
Thank you, Paul. I'll try and get in touch with you later today as you're around, but we'll see how it goes. There's Toro there, our staff governor, one of our staff governors.
Hello, everybody. Good morning still. I'm the new elected staff governor through elections, and I have worked here in Kettering for 11 years now. I am anesthetist, and I bring over 21 years of experience in working in theaters, be it India or here. And I am here because I have enrolled myself to do a health MBA at Nottingham University, and I'm quite enjoying the management side of the firm. So I think being here as a governor, I will be hopefully giving some benefits to the staff who have voted and have faith in me. Hopefully, I know Kettering is a brilliant place to work. That's why I have stuck around with it for 11 years and I have no plans to leave. But I am sure there are a lot of areas in which there can be some improvements and it can be made even a better place for the people who are working here. Thank you.
Thanks, Tara. That's good. Thank you very much. Can I move on now to Claire Gibb, please? Claire, are you there?
I am here. Good morning. My name's
good.
Claire
I can see
Nib.
you now, yeah.
There you go. Good morning, Peter. You're right.
Yep.
My name's Claire Nib. I work here. I'm the medical directorate at KGH. I joined the trust just under 2 years ago. I come from a background in project management in aerospace and engineering. However, my very, very first job was working in audiology over at Northampton. So I've seen both sites and been around it quite a lot. A bit like you described Polly at the beginning, jack of all trades. I also trained as a EMT over in America and worked in America for about 3 years on the ambulance with the fire services there. My real interest and my passion is culture change and working with people. At the moment, I've just been aligned to a new project where we're looking at improving and enhancing patient safety. And I had the privilege of hosting and being involved in the Never event, a reflective learning session we've just done. So if anyone is interested, I can provide a recording of that. I know earlier you paid reference to it. Why I got involved, best way to implement a positive change is to be involved in it, and that we have the voice heard here. Part of my role is going around talking to staff at all levels, getting that inside feedback. And one of the privileges I have is that because I don't come with any sort of expectations, people open up to me, and that I just thought it was a great place to be able to bring their feedback directly to the governors, and we can build on that together. So thank you for having me.
Thank you, Claire. Moving on quickly to Dr. Vijay, please. Do we have?
No, Dr. Vijay sent his apologies. So I think we've got Charlotte is our new elected governor to introduce herself.
Thank you, Rita. I was moving on to Charlotte. Thank you, Charlotte.
Good morning, everybody. My name is Charlotte Smith. I am a newly elected staff governor. In my role within Kettering General Hospital, I am also the Equality, Diversity and Inclusion Engagement Officer for the Trust. My background is human resources. And I wanted to become a governor, just in short, because I know we're running out of time. I wanted to become a governor because I want to be a voice for staff and in particular young people and apprentices, because I came into the NHS as an apprentice when I was 17 years old, and I really want to be able to support the future generations in their careers, and also all other staff as part of my EDI role as well. So I'm really looking forward to working with all of you.
Good, that's great, thank you. Claire Jennings, have we got Claire, Richard?
No, Claire sent her apologies as well. So we've just, I mean, we were we're pleased to be joined by Councillor Jenny Bone this morning,
Yes.
and appreciate Jenny received very short notice of the meeting, but wonder if Jenny would be prepared just to introduce herself.
No, of course. Thank you, Chair. Thank you. So very briefly, I am absolutely passionate about Kettering General, always have been. My third child was born on New Year's Day at the millennium. A unitary councillor, we were asked for who wanted to do what in outside bodies, and I'm hoping that what I put forward to the leadership convinced them to put my name forward, and I was elected. So I'm very much a hands-on person. I work for one of the local MPs, so Kettering General is very much in my inbox on a daily basis, and I just want to do something. I want to help, I want to be part of it. I'm chair of planning at Thrapston, so planning is a big passion of mine, so hopefully I'll be able to contribute. Thank you.
I'm sure you will. I'm sure you will. Thank you. I thought I saw a hand jump up very quickly and I didn't catch who it was. Do we have any questions before we move back to Alan? I don't see any coming up, so back to you, Alan.
Okay, thank you. Thank you very much, Peter.
Oh, Mo's just pushed his hand up.
Oh, Mo, you know, you have to try and keep up, Mo.
Sorry, I just would like to congratulate Richard May and his team for recruiting such a lovely group of new governors. It's a beautiful group, actually, and we, of course, Richard Abs and all the rest of the team, you've done extremely well, guys, and we welcome all our new lovely group of governors, and everyone has a speciality that we need. Excellent. Thank you.
Thank you very much, Mo. All comments like that gratefully received. So, just to finish off the introductions, I think this is the first governors meeting where Edmund Burke has been with us as our new non-exec director. Edmund, non-exec director nominated by Leicester University as part of our academic strategy. Edmund, would you like to take a minute or two about yourself?
Thank you, Alan, and hello everyone. I'm really delighted to be a part of this group, to be part of the team, to be part of Kettering Hospital Trust. Really delighted. I'm looking forward to working with you all. So my name is Edmund Burke. I'm Deputy Vice Chancellor at the University of Leicester. I've been at Leicester for just over 3 years. Before that, I was Vice Principal for Science and Engineering at Queen Mary, University of London. Before that, I had 4 years at the University of Stirling as Deputy Principal for Research and Deputy Vice Chancellor in my final year at Stirling. And before that, I was 21 years at the University of Nottingham. My research interests are at the interface of computer science and mathematics, particularly in artificial intelligence and operational research. I am president of the Operational Research Society, which is one of the 5 mathematical learned societies in the UK. And my research looks at developing decision support engines for computer systems in complex environments. So, for example, my team at the University of Nottingham, I think our highest profile project, worked with National Air Traffic Services on developing a decision support engine for runway scheduling at Heathrow, and that was implemented in 2013 and is still in use. We've also done work around hospital logistics, particularly personnel rostering. So that's a brief thumbnail sketch of me and my research interests. Really delighted to be working with you all. Thank you.
Okay, thank you very much, Edmund. I just want to spend a couple of minutes on things that are going on this year, and I know that Richard has one any other business at the end of that, so I'll come to that. Still got about 11 minutes of the call. So just to put this in context for the year, obviously we've gone through the movement to a group last year, and we spent a lot of time developing strategies. And some people criticised how much time we spent on the strategies, but we were very clear those strategies were going to be the guiding lights for the group, and having agreed them, we were not going to alter them. That has indeed been the case. So the staff that have been appointed, the group director posts, and the reports of progress that Peter talked about. Very nice of you to say it was a good board meeting, Peter. But it was an update on those strategies, and that is going to take up a large part of the board meetings going forward, different strategies every month. This was the digital strategy and obviously the clinical strategy. So we have a lot going on as part of the group, and you know, I appreciate that's a slight challenge for governors who represent Kettering, but it is about the direction of travel for the NHS as we move our services into a group, but also as to part of the integrated care system. Now, you know, I shan't bore you with a history lesson about the NHS, but we've been living in a world of purchaser and provider and foundation trusts and individual organisations for nearly 30 years now. So that's the vast majority of people's working lives. And it culminated in the Lansley reforms of 2012, which were very keen on tendering and procurement and competing for contracts and so on. And the change of direction nationally is very much towards integrated care systems, around cooperation, around coming together. So it really is quite an exercise in changing people's mindsets about how they think, both about within our group, between the two hospitals, but also as part of the integrated care system. And our exec directors and non-exec directors will have some leading roles in developing the thinking and behaviours in the integrated care system. Simon and I will hopefully, Simon, the group chief exec, and I will both be on the board of the integrated care system. But, you know, Polly, as she already said, is leading the elective collaborative. She also leads the estates function. Andy Callow, our digital lead, will be the digital lead for the system. Our chief people officer jointly chairs the people board, and so on and so forth. So one of the reasons, I just want to, for new governors in particular, but remind everybody that one of the reasons we became a group was to make sure our chief officers, chief finance officer, digital, etc., had capacity, time and space to influence and take part in the integrated care system, so that we were doing our bit to develop those services across Northamptonshire. And that integrated care system, of course, involves local government, involves our colleagues in social care, the chief execs of local government, the unitaries will be on the board, and there is, of course, a partnership board sitting alongside that, which heavily involves voluntary sector and local government. So there's a lot of effort and energy going into that in the coming year. And you should look at our group priorities, because those are the things that we will be holding ourselves to account for. I have a habit of saying at board meetings that when we agree a strategy, something ought to happen. And so the board is very keen to make sure that those strategies are live documents and that progress is being made on right across the board. I suppose the final thing to say to you is, generally speaking, a hospital board spends a lot of time balancing three things. They balance the money, they balance what we do for our people, our staff, and they balance what we do for our patients. And that balancing act is a large part of what our job is. Obviously, it's about generating efficiency, about innovation, about the academic strategy, about developing research agendas. There's a massive array of things we do, but fundamentally, it's a balancing act between people, patients, people activity, and money. And as we go into the second half of this year, money is not the big issue. Money is okay. And so the big question for us is, what can we do to get ourselves in the best possible place as we go into 2022-23, around looking after our staff, getting them through what everybody suggests will be a pretty awful winter. We're used to bad winters. It looks as if this one's going to be pretty awful. Nobody quite knows where we're going to go with the new variants, but you know, the pressure on the hospital at the moment is enormous, and all our statistical modelling and analysis shows that it is going to get significantly worse as we go into January, and will result in us having a major shortfall of beds to meet the demand on us. We've already talked about super stranded, and everything else, and the demands on ED. So the issue is, how do we get ourselves into April in the best possible position? There was reference made earlier on to resources in digital for the radical change in our outpatient services, with much more being done virtually, much more being done online, much more being done remotely, and much more around patient-initiated follow-up for follow-up appointments in that, which is a national priority in order to free up senior doctor time to do more useful things. So that's our agenda for the coming few months, and that's the backdrop in which we find ourselves. The new integrated care system goes live in April, shadow board in January, and you know, if we're going to make a success of that, which we have high hopes for, developing integrated care, really focusing on frailty, which is the major problem in the county, along with mental health, elective care, and children and young people. But from our point of view, you've heard a lot of talk today about ICANN, integrated care across Northamptonshire. That is effectively the vehicle for tackling frailty, and therefore for tackling super stranded and stranded. Sorry, I do have a bit of a cough. I can assure you it's not COVID. I get tested every time I go near a hospital. So, and just one final comment. I noticed Simon talking about visits. Visits are obviously possible, but difficult at the moment because of infection control protocols, and will undoubtedly get a bit more difficult as we go forward. And we have been throughout one of the few places that demands masks and other tests. And when we come together as a board, even, we demand lateral flow tests before the meeting, and so on and so forth. So it is difficult, but we are doing our best to try and make sure our non-exec directors, and in due course our governors, can in fact do what they need to do to be effective governors. So that's a ramble from me with 3 minutes to go. Richard, any other business? I'll come back to Graham and Peter in a minute. Richard.
Thank you, Chair. That was a wonderful ramble. Thank you very much for that. I'm sure everybody enjoyed it as much as I did. So one bit of any other business, one observation, if I may. This is probably the only meeting which I'm about as neutral as somebody can get. This is a meeting of the Council of Governors, essentially holding the non-executive to account. And just as an observation, I think from that point of view, this is probably the best Council of Governors meetings I have witnessed since coming to Kettering in 2018. I think it was really, really helpful, particularly the section around the integrated governance report. That relationship is clearly blossoming in spite of living in virtual times in all of these meetings. And on that, existing councillors will know, but for our new governors, every year we run expressions of interests for the working groups that Peter has mentioned, and for the nominated roles, who are the people that go and observe the committees of the board on behalf of the council. That annual review happens in January, so you'll hear from Richard May and myself over the coming weeks about what that process is going to look like, and we will run a competition if need be, if there are more volunteers than seats, and report that through in January. Thank you.
Okay, thank you, Richard. I'm sure you all heard that. I've got 3 hands up, which is going to be the last comment. So I'm going to go Mabel, Graham, and give your lead governor, Peter, the last word. Mabel.
Thank you very much. I'm very interested in sustainability, and the NHS says that climate change is going to be a major health problem. So could we have something on sustainability, environmental issues on every future Council of Governors meeting, please?
We're happy to comply. I know you're setting up a group of governors interested in that. I know that there is a group that Polly was talking about yesterday. I will leave that in the hands of your lead governor to faithfully represent what you want to talk about on governor agendas. Graham.
Thank you, Alan. There was a comment in the chat from Mo about inviting social services to speak, and this is more for Peter, really. I'm happy to facilitate with David Watts, the director, for him to come. I'm sure he'd be more than happy to come and talk to governors at some stage, because he wants us all to work together, just as the hospital wants to. So I'm probably seeing him this afternoon, so I'll mention it.
Thank you very much. Thank you very much. And finally, Peter.
Thank you for that, Graham. Just a quick comment, Chair. Kettering has 2 foundation trusts, and for the sake of the new governors, just to advise that Northampton is not a foundation trust, and therefore they don't have governors. But the other foundation trust in Kettering, NHFT, do have governors, and we are working alongside them in a number of areas, primarily the ICS issues, but we're trying to meet with them on a number of fronts, particularly on communications. Their constitution and ours are very similar, but more importantly, their members are probably ours as well. So it's important that we work together. So you'll hear a lot about that in the coming period. That's all I want to say. Thank you, Chair.
Lovely. Thank you very much, Peter. Am I done? Yes, I am. We're out of time. Thank you very much for a good meeting. I hope you all got something out of it. I'm sure all the execs did and the non-execs who were present. So thank you very much. Particularly thanks to Paul Bremner for saying nice things about the chairman. So thanks very much. Take care. Bye.
Thank you, Chair. Thank you, everyone.
Goodbye.
Thank you, everyone.